So I just stopped recording, so I don't think we really got anything at the beginning, and I've just restarted it now.
Has that come up? Has that come up on anyone's screen?
Yeah, I can see Ali, but it's just we can see the Microsoft Teams page in front of the slides.
Okay, right. I'll try and get rid of that. Okay,
Yeah,
and
that's great.
there we go. Okay.
Yeah, perfect.
And if you go to, can you go to slideshow, Ali? That might make it a little bit easier.
Yep.
So you have to move me. That's good. Okay, here we go. So this is a case that the kind of thing you'll all be familiar with. A previously 15-year-old boy presented to adult A&E with a history of abdominal pain for a week. He had attended A&E a week earlier with similar symptoms. An examination reveals a mildly tender mass in his right iliac fossa, but no other relevant clinical findings. So I won't dwell on things because I know we've lost a bit of time, but just people that are in Glasgow, there isn't quick questions here, but what sort of things would you want to ask them to arrange in A&E? What can be done then and there?
So some of the answers are some blood tests, some imaging like X-ray, ultrasound.
Yeah, absolutely. So that's kind of what he had done. So if Ali, if you press next twice, that's right. Okay, so he got an ultrasound scan done from A&E, which showed 2 large intra-abdominal masses with acidic fluid, and he had some blood tests, which included an LDH, which was elevated, and urate, which was elevated. Yeah, this would be consistent with malignancy, though clearly they still want there was questions about whether this could be an appendicitis that's developed an appendicitis or a intra-abdominal infection essentially from that. But the LDH is elevated, not clearly indicating that it must be lymphoma, but would make you suspicious, and the elevated urate as well. So if we just go on to the next slide, he then had more definitive imaging. Okay, so if just Ali, if you just press next, that'd be great. And that confirmed these masses, and there was also fluid. So it's that kind of situation where we want to try and get a diagnosis, and the best way of doing that. So just going to Edinburgh, Rosina and your haematology colleague, again, no trick questions, but what sort of things are you thinking about next? I've maybe lost you a wee bit there. So, well, I'm sure you are thinking about extending the imaging. We've only got imaging of the abdomen and pelvis. We want to get a diagnosis. So we've extended the imaging and seen that it's got a CT chest that's normal. That's relevant, isn't it? Because we don't want to send someone for an anaesthetic for a biopsy if they've got a large mediastinal mass and airway compression. So it's always important to ascertain that there's not mediastinal mass. The interesting adult versus pediatric, obviously. So in pediatrics, essentially whatever we do, we're going to do an anaesthetic for it. But in adults, local anaesthetic would be a reasonable thing to do to try and get either a guided biopsy by radiology of one of these masses with some of the fluid. The benefit of taking some of the fluid is you can do flow cytometry on it, which gets you an answer more quickly than sending a sample, a material to pathology, where they obviously need to wait for immunocytochemistry, the stains to essentially work. So we want to get a biopsy and we want to get some of the fluid. The other thing to remember is that lymphoma, particularly certain types of lymphoma, can involve the bone marrow. So if a child is getting an anaesthetic, it's perfectly reasonable at this point to get a bone marrow off. And you'd also, I think, in the adult sector as well, consider doing a bone marrow early, because it's something that can be looked at quickly and potentially get a diagnosis faster than a diagnosis from the pathology team, or at least a kind of provisional diagnosis, which might enable you to start some initial therapy if the patient's becoming more unwell. So if we look at the next, so if we click it, that's right. Okay, so that's the peritoneal fluid. And these are sort of blast-like cells as described there, and they have markers consistent with lots of activity and consistent with them being B cells. Bone marrow is the next one. If we click it again, thanks. So this bone marrow was normal, and then he had a biopsy which confirmed these were B cells. They're proliferating very rapidly, but they were TDT negative, and they had a more mature phenotype with surface immunoglobulins. This wasn't a lymphoblastic lymphoma. This looks like a mature B cell neoplasm. So if we go on to the next slide, this is the classic stain, and this is the sort of starry sky that everyone learns about as medical students, I guess, Burkitt's lymphoma. And the next slide, just to give you some idea of what's seen down the microscope, I'm sure you've seen this in pathology meetings. So the Chi-67 at the top left indicating that virtually all the cells are proliferating, and then two classic positive markers, top right BCL6, bottom left CD20, and then BCL2, bottom right is negative, which is consistent with this type of lymphoma, more likely to be positive if it was, for example, a diffuse large B cell lymphoma. So there's some classic immunophenotyping. And the next slide gives you the classic results for Burkitt's, positive for mature B cell markers, negative for some of the more immature, and some of the T cell markers as well. So that's sort of classic immunophenotype. So a lot of that you could get from flow cytometry, and you can confidently diagnose a Burkitt's lymphoma from an aspirate of pleural fluid or of their acidic fluid. And certainly if their bone marrow is involved, you could get it from that, thereby saving you having to obtain a chunk of material from the abdomen if that's going to be risky. So next slide. So one thing is important to know about, particularly for registrar training, and I guess for haematology registrars as well as paediatric hem-onc registrars, is the association of Burkitt's with the MYC gene. So this little diagram shows you that MYC is involved in gene expression and promoting the cell cycle. So you can see it inhibits some of the inhibitors, and it promotes some of the drivers of the cell cycle. So it's a normal thing, but if it's dysregulated, so there's more activity than there should be, perhaps because the gene has been translocated and now is next to another gene that's constitutively on, then the cell cycle will be driven to continue. And this is one of the key triggers for cancer. So the classic translocation that brings the MYC gene into a situation where it's constitutively active is the T814 translocation, seen in most cases with Burkitt's. So again, tumor board meetings, have we got the MYC status? Have we got, and this would be a classic finding for Burkitt's. There are other translocations, 2.8 and 8.22, I guess not to be confused with 9.22, which is a Philadelphia chromosome. But usually in a Burkitt's lymphoma, you'll have a recognized translocation involving this part of chromosome 8. Of note is that not all Burkitt's lymphomas do you find a MYC translocation, though you do in most, and not all lymphomas that have a MYC translocation are Burkitt's lymphoma. There are types of diffuse large B cell lymphoma which might have a MYC translocation, but it's certainly a classical finding. So next one. So how do these patients come to us? Well, we all remember the cases. It's always pretty dramatic, isn't it, with Burkitt's lymphoma. usually via the surgeons. They're often on a surgical ward or in A&E with an abdominal mass, or they're in intensive care or HDU because they've presented decompensated. Similar, really, adults to children. As I say, they've usually got an abdominal mass. They've usually got B symptoms. There is this sort of group of Burkitt's that present with head and neck, so sort of sinus involvement in neck nodes, maybe extending intradurally, that are known and seen more in pediatrics and adults. Bone marrow involvement is not uncommon, which is why it is a completely reasonable thing. If you think someone's got Burkitt's, maybe a Friday, you're not able to get a biopsy, maybe there's not much fluid, it's perfectly reasonable to do a bone marrow because you might get the diagnosis before the weekend and before the surgeons can get in there. And if you've got Burkitt's in the bone marrow, then you've got your diagnosis. And CNS involvement is recognised. The numbers aren't there for the children because I couldn't find a study that kind of just broke down into CNS overall. It was mixed in with some of the head and neck area, but essentially CNS involvement is not uncommon. We've had children or teenagers present with spinal tumours, cord compression. That's a recognised presentation pattern. And disease out with the nodes is common. I've referenced the LY10 study. That's an adult trial, 16 and overs of Burkitt's lymphoma. So if we go on to the next slide. So in some ways, you could say pediatric lymphoma is pretty easy compared to adult lymphoma from the point of view there aren't that many types that present. And there's not that many treatment protocols. So the haematology training that's there in Edinburgh, we list off hundreds of different treatment protocols and different situations, many different types of lymphoma. But essentially in children, you've got the B cell and the T cell, and B cells are usually Burkitt's lymphoma, more rarely diffuse large B cell, and very rarely mediastinal large B cell. There is also the group of patients with lymphoblastic lymphoma. And then the T cells are usually T lymphoblastic lymphoma, though we do see anaplastic lymphoma. And you can see that the B cell, mature B cell ones, are treated with the Inter-Ritux protocol, which we know and love. And then the lymphoblastic lymphomas are treated as ALL. And then the T cells are treated according to the ALCL 99 protocol. And that takes up 60% of lymphoma in children, and the other 40% will be Hodgkin's lymphoma. I mean, there are other types, and if we go on to the next slide, gives you an idea of the variability. So you can all sort of squint and go close to the screen, but you can see if you look at the purple one, you can see that's Burkitt's. You can see how prevalent that is in children and then becomes rarer as you get older. And you look at the red, the lymphoblastic lymphoma, you can see again prevalent in young, getting rare as you get older. But then you look at the other types, you see yellow, the follicular lymphoma, which lots of patients with that who are elderly, that's rare in children. And then things like marginal zone lymphoma, rather, the sort of green one, and then a sort of funny pinky colour mantle cell lymphoma. These are rare in children, but common in adults. So you get the idea that there's common types in children that become rarer as they get older. And Burkitt's and lymphoblastic lymphoma would fit into that group. Okay. And then see, anaplastic's got like a little rise in the teenage years, and then it dips down again. That's a sort of light blue one. So that's, I think I've read, there's reference there on where that came from. So go on to the next slide. So this is now treatment of Burkitt's lymphoma. So, I don't know. I don't know whether Rosina can talk, but Rosina, treatment of Burkitt's lymphoma, this protocol, how do you guys in Edinburgh get on with this protocol? We find it quite difficult to read and follow across in the West, but maybe that's just us. What do you think about it? I'm not sure that Rosina can talk, but oh yeah.
Stopped it again. What was your question?
Okay, so have you recently used the Inter-Ritux protocol across in Edinburgh?
In adults, I've actually only seen them being treated on the adult protocol, even when they've been 16, 17 years old with Orthodox-M.
Okay, so, well, the pediatric protocol, we've got a few going through it at the moment, is pretty complicated to say the least. I think part of it is the way it's been written. I think it probably could be written more clearly, but also partly because they've desperately tried to, I think within the protocol, subcategorize various groups to ensure they get optimal therapy. So if we go on to the next slide, the backbone to it is the LMB 96 protocol, and I've put one of the publications there, one of the key publications from 2007, quite a long time ago. And of note is this particular trial that I'm going to be talking about, the protocol we use, has been published recently in the New England Journal of Medicine in June. Okay, so if you were interested in reading about this trial and the outcomes, then has been published. There are quite a few publications from the LMB 96 trial. You know, there's separate publications looking at different risk groups. There's publication looking at head and neck involvement, CNS involvement. So, you know, there's quite a few publications that you could read or look at, which might be particularly applicable to a patient that you might have. So go on to the next slide. So I've tried simplifying it a bit. And to keep things from being too dry, I'm not obviously going to go into massive detail. I'm just trying to pick out the key things. So everyone gets this COP induction. COP is cyclophosphamide, vincristine, and steroids. It's relatively low intensity. And interestingly, there have been cases I've dealt with in the adult side using the protocol Rosina reference there, Codox-M IVAC, where you kind of wonder whether they would have been better off with a more gentle induction. The idea is to initiate control of the disease without causing significant toxicity from the point of view of tumor lysis. And usually, and I wonder also the benefit of this, often these patients are pretty unwell when they present. Maybe they've just had an operation or just presented with a perforation, or they've just presented with a seizure or something like that. Dermot Murphy's got a nice analogy. He talks about this being, you've got a steam train coming towards you, which is the Burkitt's lymphoma, and you're not immediately going to push it backwards. Initially, all you can do is slow it down. And that's the kind of his analogy for the COP induction phase, which I think is a very good one. You then get 2 cycles of R-capadum, which, as we all know, is pretty toxic, mainly because it's front-loaded with methotrexate and anthracycline in a patient usually who, as I said, have just had an operation. Maybe he's got a stoma, it's maybe got sort of a degree of tumor lysis. So it's a pretty toxic induction. In group B, the 2 capadums are the same. In group C1 and C3, they're not quite the same, which is where the first bit of trickiness in the protocol comes in. After the second capadum, the group B patients, and I'll define what they are in general terms on the next slide, get R-SIM, and they get 2 of those, and they're the same. And you'll notice there's a response assessment after the first one. If you've still got active disease or potentially active disease after the first R-SIM, you upscale to C1. Okay, so it's a bit like regimen A's can go to regimen C if they've got MRD. The group C's don't get their first assessment, or their second assessment rather, until after PSI. There's 2 groups of C's depending on the presence of CSF disease, and again I'll mention that on the next slide. But essentially they get 2 CIVs, which are slightly different between the 2, and then they get 2 maintenance blocks. Okay, again slightly different between the 2. So that's, when you put it like that, it looks quite simple, doesn't it? You can tell parents you're going to get an induction treatment and then 4 or 6 cycles of chemotherapy. Chemotherapy is toxic. You're likely to be an inpatient for much of the time during each phase, and hopefully get a short break in between each one. However, the protocol mandates you really should move straight onto the next chemotherapy block as soon as the patient has count recovered and is fit enough. And being fit enough often is the problem. Usually the cycles are sort of 21 to 28 days before you're ready for the next one. Though it can be, as we all know, 35, 42 days before the patient has recovered from their methotrexate-induced mucositis or their typhlitis and all the other complications that we see. So we've gone to the next one. So this is trying to simplify the different groupings. One thing to bear in mind is that the Inter-Ritux protocol is not all Burkitt's lymphoma, it's just those considered high risk. So the lowest risk group, if you like, are a group that have stage 3 disease with a high LDH, because previous publications have demonstrated that an LDH of 2 times the upper limit of normal was a poor risk factor. Or they're stage 4, but they don't have disease in their central nervous system. And if they do have bone marrow involvement, it's low level involvement. Greater than 25% would be classed as a Burkitt's leukemia, which confusingly is called B-L in the protocol at various times. So that's group B. If you have CNS disease from the point of view of disease, lumpy disease in the CNS, or you've got bone marrow involvement greater than 25%, you are group C1. But as you remember, you could also be a C1 if you're a group B patient who has needed to escalate because they've had an insufficient response. So if you like, it's a first step up. And the final group are those with CSF disease. So disease in the CSF analysis, and that's because there's been a publication clearly showing that if you've got CSF cells, that is an independent poor prognostic factor, irrespective of whether you've got CNS disease or not. And there's a particular, say, publication referencing that. So CSF positive patients are seen as particularly high risk, and that's why they get this very toxic C3 treatment. So that's the main 3 groups. So if we go on to the next slide. So picking out the results from the publication. So the interesting thing about this trial is it was stopped early. It stopped back in 2015 because the rituximab group were doing well, and the power calculation showed that there was likely to be a significant difference. So therefore, obviously not considered appropriate to continue randomizing patients to not receive rituximab. So the publication is of a reasonable number of patients, 328, so exactly 164 in each group. And when they published it, there was 3.5 years of follow-up. And you can see there that the event-free survival was significantly better in the patients who received rituximab. And that's manifest as less events in the rituximab arm and less deaths. The deaths in the rituximab arm, 3 of those 4 deaths were treatment-related toxicity, whereas in the chemotherapy alone, though there were 3 deaths from treatment-related toxicity, there were also further 14 from progression of disease. The toxicity was considered higher in the rituximab arm, and interestingly, there's this additional factor of a significantly increased proportion of patients have a low IgG at a year after treatment. So rituximab does have a profound effect on B cells, which is manifest still at a year after treatment, and potentially beyond that. Certainly, anecdotally, I've got patients coming to the late effects clinic a number of years after treatment who have still got low IgGs. Is that a risk for infection? Is that a risk for autoimmunity or future lymphoma development? Are these patients essentially like a common variant immunodeficiency group? We don't know. So that is the results, and that's why we give rituximab to the high-risk patients in combination with chemotherapy, despite the potential risks of infection, as you can see there, and maybe an ongoing risk that is ill-defined at this stage. So go on to the next slide. So what about the others? So we had this interestingly recently because we had a patient who presented with a tonsillar mass that was eroding into their oropharynx and not CNS, but they'd been biopsied. So they had sort of isolated disease that had not been fully resected, but they didn't have the high risk features. They had a normal LDH, no bone marrow disease, for example, and they were not a stage 3 disease. So these are in the old group B group, the sort of lower risk patients. So these weren't patients that were put into Inter-Ritux. So we don't know that rituximab improves outcomes for these patients. So we did a bit of emailing around, and it seems that some centres are giving all patients rituximab, though accepting that there's not evidence that it's required, but it may do good and it's unlikely to do harm. Or is it unlikely to do harm? Because we have evidence that the risk of complications is higher in those patients receiving rituximab. So we elected not to give rituximab to this particular patient. If you look at the previous LMB publication of this lower risk group, you'll see that the event-free survival at 4 years is greater than 93%. So even if rituximab was going to do good, you'd have to treat an awful lot of patients, I think, to show an improvement in event-free survival. The next low-risk group are those that have had fully resected disease. Maybe those that have presented with an abdominal mass. I had a patient like this a few years ago. Again, thought to be appendix mass, went to theatre, they took it out, took some nodes out, nodes were negative, scan was normal afterwards. They had a fully resected disease. So this was a patient in the very good risk group, group A. So in the previous trial, they got something called COPAD ×2. So the adult trainees there, Rosina, you're an adult trainee now, will look at that and recognise that as a bit like CHOP, isn't it? So they basically get 2 cycles of a CHOP equivalent, and then the outcomes are incredibly good for these patients, greater than 98% 4-year event-free survival. So, these patients who have fully resected disease, unlikely to require extensive chemotherapy, rituximab unlikely to add any benefit, and this is in the days before PET scanning as well. So you might be able to enhance your pickup of patients with the residual disease better nowadays for the use of PET scan. Okay, so that's the group A patients and the group B patients who are not in the Inter-Ritux protocol. So if we go on to the next slide. Now this is kind of for interest, but it's just to give you an idea, what do we give to these children when we give Inter-Ritux? Risks of long-term toxicity, and I've put Codox-MI back at the end there as well, just for comparison. So you don't give them much vincristine, so unlike the ALL patients, they don't get the foot drop and the other vincristine toxicities that we're used to, the ileus and the local cord palsy, so don't get much vincristine. I've left the pred bit blank because I gave up trying to count the days of steroids, but it's less than they get in ALL therapy, and it's sort of 17 days, 27 days, depending on which protocol and which arm they're on and how long you taper it for. But avascular necrosis is not a particular risk with this protocol. I have had one patient with AVN, though she was profoundly unwell, was in ITU, and I wonder whether there was additional factors contributing to her developing AVN of her hip. So AVN is not considered to be a significant risk. It's prednisolone and it's not such prolonged courses. They do get anthracycline, but you'll see they get less than 200. So the risk of long-term cardiac toxicity is therefore relatively low. Though it is interesting, isn't it, to notice that the adult protocol actually has got even less anthracycline, just 80 in Codox-MI back. The cyclophosphamide increases with the different stages of the treatment. So that is a risk factor for infertility. So group C2 are at significant risk of infertility. Group C1 are at risk. Group B, relatively low risk. Codox-MI is a reasonable risk of infertility because they get 15 grams per meter squared of ifosfamide in addition to their cyclophosphamide. So, for example, I can think of a female patient I've got at the moment, post-treatment, 6 years of Codox-MI who's entering premature menopause. So I think Codox-MI does carry the risk of reduced fertility. Etoposide, reasonably high doses in C1 and C2, which, as we know, is the risk of secondary AML. Low dose in Codox-MI. They get a lot of cytarabine, not significant long-term risks associated with that, but risks, obviously acute risks of cytopenias and fevers. We all know what it's like treating patients with high doses of cytarabine. And they get a lot of intrathecal treatment. Now, I wouldn't put my hat on the group C1 and group C2 being exactly right. I counting them, essentially they seem to get between 10 and 14 intrathecals, which is around about double what the group B gets. They get a lot of intrathecal treatment, and they get an awful lot of methotrexate, almost like solid tumor doses of methotrexate, which is linked, I think, to the toxicity. You know, there's sort of mucositis, the skin toxicities, the low counts, the liver upset, the renal impairment that these patients can suffer. So if we go on to the next slide. So why do we do all this? Relapsed Burkitt's lymphoma obviously is a very difficult situation for a family to deal with, because essentially, this is a graph published in 2012 actually, based on patients treated on the LMB 96 protocol. So there's a similar backbone, though not with rituximab. And it was showing that those who relapsed either on treatment or within 6 months of finishing were essentially incurable. The later relapses could be salvaged, though many of them weren't. And rituximab, not having had rituximab before, seemed to be in their favour, and using rituximab therefore in salvage was beneficial. So the risk of having a patient in an incurable situation is pretty high, essentially. So relapsed Burkitt's lymphoma is bad. So if we move on to the next slide, the current salvage protocol is RICE, so rituximab, ifosfamide, carboplatin, etoposide. So, you know, they've had rituximab before, they've had, so giving them a slightly different alkylating agent. They haven't had carboplatin, but they have had etoposide. So you can sort of see why, you know, is it really going to work? This protocol was published in 2009, and you can see the responses were there. Of the 21 patients that were given it, 6 managed to achieve stable enough disease to have a stem cell transplant. Of the Burkitt's lymphomas in that group of 21, 4 of the 14 had achieved a CR. So, you know, patients did achieve a response with RICE, but it's not clear whether the patients had had rituximab before. I couldn't sort of pick that out. It's quite a short publication. It might even be a letter, you know, rather than a sort of full-on publication. So, but that is what we use as first-line salvage, RICE. But clearly, these patients have had multi-agent, high-intensity chemotherapy. So if they've relapsed, particularly if they are refractory, then it's likely they're refractory to all chemotherapy. So if we look at the next slide, this gives an indication of where we're going next. So the key one to know about is ibrutinib for Burkitt's lymphoma. So in Burkitt's lymphomas and in other B-cell malignancies, the B-cell receptors are constitutively active. So if we look at downstream signaling from B-cell receptors, one of the downstream pathways is this Bruton's tyrosine kinase, BTK. So they've looked at the signaling pathways through gene expression profiling and found that this pathway is active in Burkitt's lymphoma, in pediatric Burkitt's lymphoma. Itself is a pathway that then triggers various factors which drive proliferation, ones which you'll recognize, MAP kinase, NF-κB, and mTOR. So ibrutinib is a drug that can therefore have potential benefit in Burkitt's lymphoma. Now, if we go on to the next slide, the SPARKLE trial, what a good name, is RICE with dexamethasone, they've called it modified RICE, and ibrutinib. And they give it to 11 patients, and it's been published. Well, preliminary findings have been published this year. The findings also include ibrutinib combined with a similar protocol to ICE, which is what the other Europeans use, not the Europeans, but other Europeans use. So we'll see that if you group all these patients together, there are patients with refractory relapsed Burkitt's lymphoma who achieve a response. And some of those achieve a complete response, and therefore might be in a situation where you could do a curative procedure such as an allograft. However, the numbers still aren't great, are they? So it doesn't mean that this is a transformative for relapsed refractory Burkitt's lymphoma, but it is a potential option. And it's what certainly has been recommended recently to us when we've had a patient with relapsed disease who's not responded to conventional salvage. So just when I've focused there quite a lot on Burkitt's lymphoma, I think I've just got 2 more slides after this just to give a little outline of some of the rarer types, just if you like, pick out some key things. So if we go on to the next slide, I've talked about Burkitt's there. The other 2 types you're likely to see, I'm not going to talk about lymphoblastic lymphoma because I think that's probably a separate ALL type presentation. I was just going to talk about diffuse large B-cell lymphoma and highlighting mediastinal B-cell lymphoma. So diffuse large B-cells in general, they can be like Burkitt's, nodal and extranodal. They can involve the CNS and bone marrow, but less frequently. And there is this particular subtype called primary mediastinal large B-cell lymphoma, which you should know about. Anaplastic, I'm leaving for sort of chapter 2 if we're going to talk about T-cell disease. So if we go on to the next slide. So some take-home messages for diffuse large B-cell lymphoma. So as the adult treatment, very common in adults, it's sort of bread and butter of working on a hematology ward is patients receiving or complications of receiving R-CHOP chemotherapy. So like Burkitt's, it's a mature B-cell neoplasm, therefore markers are similar, 19, 20, 22, 79A. There's 2 key types, which were originally defined by gene expression profiling, but now can be defined by immunohistochemistry. There's a germinal center type, and then there's a slightly poorer risk activated B cell type, ABC type. So ABC type is more common in elderly. Children are nearly always the germinal center type. There's another interesting feature, if you like, that may come out in the pathology of a particular diffuse large B cell, and that's whether or not it's a double hit lymphoma. So again, you'll know this from adult MDTs. You might present particularly a double hit lymphoma where the patient has 2 of MYC, BCL2 or BCL6 translocations. This is very rare in pediatrics. Okay, so double hit lymphomas are rarely seen in pediatrics. And what they give, well, they do in the West, a double hit adult lymphoma. If they were fit for it, they would get Codex MI back. You know, it's a similar sort of idea. In pediatrics, they'd get Inter-Ritux, which is a similar multi-agent chemotherapy. So it's likely that the double hit lymphomas, if they were to present in pediatrics, will be treated optimally anyway. So diffuse large B cells in peds are treated the same as Burkitt's. The outcomes of R-CHOP in adults, which is significantly less toxic, are very good. So do we maybe overtreat a lot of the diffuse large B-cell lymphomas? But it'd be difficult to step back because, as I say, the outcomes in pediatrics with the protocol that's given are very good. So that's just a little slide about diffuse large B-cell. And the next one I've got a single slide on is primary mediastinal large B-cell lymphoma. So this is rare in pediatrics. It's pretty rare in adults as well. In adults, it stimulates a lot of discussion, and it actually stimulates a lot of discussion in peds as well. So previously, primary mediastinal B-cell lymphomas in children got the same as Burkitt's and diffuse large B-cell. In other words, they got the FAB LMB 96 protocol, you know, the multi-agent, lots of methotrexate, CNS-directed therapy, etc. And when they looked at the subtypes and who did well and who did not so well, it became clear that primary mediastinal lymphomas usually it was teenagers, so 12 to 17-year-olds, were doing badly. So 66% 5-year events-free survival, so significantly less than the 80-90% you'd be seeing with other lymphoma types. Now, in adults, there's a big debate between R-CHOP with consolidation radiotherapy versus dose-adjusted EPOCH-R, which is a bit like CHOP with fractionated doses and etoposide in there as well. Because these 2 protocols are both, some argue, equally effective as each other, and they give maybe as much as 90% progression-free survival, so significantly better than the LMB protocol in younger teenagers. However, CHOP we don't tend to like in children because of the high dose of anthracycline, 300 milligrams per meter squared. And CHOP generally is followed by radiotherapy, because usually patients have residual mediastinal masses, particularly at their first assessment time point. And mediastinal radiotherapy in a teenager carries significant risk of long-term toxicity. So because of this, and because of the benefits seen of DART EPOCH-R and the fact that patients are less likely to require post-treatment radiotherapy, they took this protocol and have given it to younger teenagers. However, the results are surprisingly not very good. Now, I can't find that this has actually been published fully, but it was published in abstract form in 2017. And actually, the event-free survival at 2 years with DART EPOCH-R was only 69% in children, not significantly different from the previous protocols. So maybe it's a numbers thing, maybe they haven't treated enough. Maybe there's something inherently different about primary mediastinal B-cell lymphoma when it occurs in younger teenagers as occurring in adults. I don't know. I don't know the answer to that. But it's interesting. We haven't had a primary mediastinal B-cell lymphoma recently. So what I'm not sure at is, if we discuss this case nationally, is what the national approach to a, say, 15-year-old girl with primary mediastinal lymphoma would be. I mean, I would favour dose-adjusted EPOCH-R because that's what I'd give an 18-year-old girl, for example, if they presented with it. But I'd be interested to know whether or not that is a supported approach. So that is my last slide. So I know it's a bit difficult on Zoom to ask questions, but I guess if we go to Glasgow, so Boo Boo and people that are there, has anyone got anything they'd like to ask or say?
Yeah, sure. Thanks a lot, Dr. Heaney. I thought that was really good. I found it really helpful showing us the risk stratification, how you'd put people onto different protocols, and the criteria for that's nicely laid out. I guess one of my questions, I don't know if you'll remember from the case that you discussed right at the beginning, but I was wondering, you said a lot of the time you can actually get a diagnosis from the bone marrow. If the patients, from your experience, if they've basically had a diagnosis from the bone marrow, have they always had an abnormal full blood count preceding that, or could they have a normal kind of looking FBC and then still have an abnormal marrow?
Yeah, they could have, because we've certainly had patients with, they could just have a 10% infiltrate. I mean, often we end up, so yes, short answer to your question is yes. The difficulty is often when you've got a lump in the abdomen, you don't know whether it's going to turn out to be a solid. As we know, what you need diagnostically for a solid tumor is more than you'll need to diagnose lymphoma, because clearly they need to do a lot more tests, need fresh sample genetics. You'll know better than me, but so often the patients do need to be teed up to go to theatre, and it's just we can probably think of examples. You could get the diagnosis from flow on a bone marrow aspirate, and thereby save the patient going to theatre. But day to day, often they need the GA for the aspirate. The GA, they only want to get one GA because maybe they're not very well at the time of presentation, and the surgeons could do the procedure tomorrow. It often ends up all happening together, doesn't it? But fundamentally, you can get the diagnosis from a bone marrow in many of these patients.
That's great. Thanks very much. And again, if there's the other thing we've done with these sessions, if anyone's got questions, you're also welcome to type them into the chat function and I can read them out. It's not got anything coming up yet.
That's okay.
Is there any other questions from anywhere else? We've got quite a few more attendees now. I can see Aberdeen.
I'd just be interested. Actually, I'm not aware of a primary mediastinal presenting in Aberdeen or Edinburgh recently in the paediatric side. I guess, Rosina, you maybe wouldn't know because I know you're working the adult side at the moment. But yeah, it's actually though in Edinburgh. Rosina, do you know? Because it definitely seems to be a divide around the country. are you giving your primary mediastinal B-cell lymphomas R-CHOP with, PET-directed radiotherapy, or are you giving them dose-adjusted EPOCH-R? Or do you know?
I'm not sure if she's still here, actually, Dr. Heaney.
That's okay. Well, if there's no further questions, that's absolutely fine. And if people are interested, I don't mind doing something on T-cell disease, and I'd probably focus it on anaplastic large cell lymphoma. There are some interesting developments there with regards to new agents and new ways of risk stratifying anaplastic lymphoma. So, pediatric oncology trainees, well, any trainee might be interested to hear about that, to save them having to read about it and find other references and things. And if anyone wanted a reference that I've talked about but haven't put on, or I haven't put on in detail, then just email me and I could give you the reference. That's not a problem.
Thanks very much for your time. That was a really good talk. And just everyone that's on just now, it's just to let you know there's a little survey monkey that Victoria's posted in the chat. If you don't mind trying to fill that out while the talk's still fresh in your head, just helpful to get some feedback and for the speakers as well. So thanks very much, everybody. Okay, cheers then. Bye-bye.
Thanks, Nick. Thanks. Bye.